This morning's general session will cover the evolving transplant landscape. There's quite a bit going on in the transplant arena, and that is an area that is of great interest to patients. And this morning, we're going to have several experts provide us insights from their perspective about what their organizations are involved in with respect to transplantation. Our first speaker is going to be Dr. John Snyder, who is the director of the Scientific Registry of Transplant Recipients. He is also the director of Transplant Epidemiology for the Hennepin Healthcare Research Institute. John is also a good friend. I've had the pleasure of serving on the SRTR for several years, as well as several other AAKP patients serving on important subcommittees that are involved in transplant-related activities. So let's hear from Dr. Snyder. John?
Hello, my name is John Snyder. I'm the Director of Transplant Epidemiology at the Hennepin Healthcare Research Institute in Minneapolis, Minnesota, and I have the privilege of serving as the Director of the Scientific Registry of Transplant Recipients, which I'm here to tell you some information about. I first want to begin by thanking the AAKP for the generous invitation to be with you today. I have gotten to know Mr. Knight over the years and consider him a friend, and really am thankful for the opportunity to talk with you all about the work of the Scientific Registry of Transplant Recipients and the fundamental direction we're taking to engage systematically the patient voice. And so my thanks to the AAKP for the opportunity to be with you today. Just a brief background. As I've mentioned, I serve as the Director of Transplant Epidemiology at Hennepin Healthcare Research Institute. We serve as the contractor with the federal government to operate the Scientific Registry of Transplant Recipients. And so I just note here that these views are expressed do not necessarily reflect those of the U.S. Department of Health and Human Services. I also have the privilege of serving on a few boards of directors in the field of organ transplantation. And so I just want to acknowledge the good work that's being done by Donate Life America and the Alliance for Organ Donation and Transplantation. I'm proud to serve on those boards. I also have the opportunity to serve on the clinical policy board of the organ procurement organization that serves Minnesota, North Dakota, and South Dakota, and that is LifeSource. By way of background, I'd just like to point out where the SRTR sits in the operation of the nation's transplant system. The U.S. Department of Health and Human Services has the division, the Health Resources and Services Administration, which has a division of transplantation that operates two major contracts in the field of solid organ transplantation for the United States. On the left, we have the Organ Procurement and Transplantation Network, which is operated by the United Network for Organ Sharing in Richmond, Virginia. And a sister contract to that is the SRTR, the Scientific Registry of Transplant Recipients, which is operated by my team at the Hennepin Healthcare Research Institute in Minneapolis, Minnesota. And the distinction I like to make between these two contracts, the OPTN UNOS system is, I would say, operates the nuts and bolts for the people in need of kidney transplants when they get put on a wait list. The OPTN manages that process, makes sure the donors are being matched correctly and organs are getting to where they need to be and transplanted into those recipients. The SRTR serves primarily a research function as well as a public reporting function. So we are charged with monitoring the status of solid organ transplantation in the United States and also consulting the policymaking bodies so that when they are considering changes to, for example, kidney allocation systems, our team may run a number of analyses for those committees to consider the data and hopefully make a correct decision in terms of how they're, or at least an informed decision in terms of how they're going to alter the policies to benefit patient outcomes. So the SRTR was established by the National Organ Transplant Act back in October of 1984. And this just gives you the public health law reference here. The Secretary shall, by grant or contract, develop and maintain a scientific registry of the recipients of organ transplants. And that registry shall include information respecting patients and transplant procedures as the Secretary deems necessary to an ongoing evaluation of the scientific and clinical status of organ transplantation. A lot of words, but essentially a scientific registry exists to help improve and monitor the nation's transplant system. So one of the main functions we serve is a public reporting function. We manage the website srtr.org, and you can see the reference there. And there's various performance metrics along with some other tools there that hopefully will provide useful information to patients in need of transplant. On the left here, I have an image of the United States. This is simply an image of some of the reports we have available at the portal into those reports for the 57 organ procurement organizations in the country. Those are the companies charged with working with deceased individuals to hopefully make their organs available for transplantation around the country. So those are designated by those colored regions on that map. So you can find reports about their performance and of those organ procurement organizations there. On the right, I have an image of one of the main pages of one of the transplant programs. In this case, I just picked out Ohio State University's transplant program, their kidney transplant program. And you can see just a highlight here of where that program is located, along with a couple key metrics that I can tell you a bit more about. One of the things we've worked on over the years is you will find if you peruse our reports that there are a number of very complex statistics in these reports. Assessing transplant program outcomes is a tricky business, right? So we have complex statistical models that we use to analyze outcomes and try to compare apples to apples across the different transplant programs. And so one of the things we're very proud of is we have, over the past 10 years, been really making a concerted effort to make the information more useful and understandable to patients. One of the ways we've done that is we've created these 5-tier systems that simply try to summarize a couple complex metrics into sort of, I think we're all familiar with looking at sort of 1 to 5 rating scales. And so in this example here, again, from Ohio State's program, we look at 3 main components of transplant program performance and rate them into these 5-tier systems so that patients can quickly get a good sense of how things are going at that program in the recent years. We look at survival on the wait list. So how well is this programs, are these programs patients staying alive while they're on the wait list in order to get organ offers? In the second one in the middle, how quickly is this program generally transplanting their patients? We know that all patients are unique and they have unique circumstances. And so we try to make adjustments in these models for the types of patients on their list and how acute they are. And so that is an overall assessment of all the patients on their list. Is this program transplanting them quickly or slowly? You can see this program here gets their patients transplanted quickly with a 5-bar rating in that as well. And then we look at outcomes. The summary here is first-year kidney survival after your transplant. So are you alive with a functioning transplant 1 year after the transplant? We know from talking with patients that 1 year is absolutely nice, but patients would also like to know longer-term outcomes. Now, within the reports, if you click through into more detailed data, we do have a 3-year outcome available, and we are currently working on a 5-year outcome as well. So hopefully stay tuned and you will see that 5-year outcome presented in the future. You'll find we've tried to produce some simple, engaging graphics in these reports. Here's a simple summary of the inflow and outflow of the Ohio State University Kidney Program's waiting list. And so you can see starting with 516 people in July of 2019, and then we go through a year period, and now they have 530 on their list. You can see the reasons that patients are removed from their list as well. And these reports update every 6 months. And so you'll see every 6 months in January and July, these data will update and show you the most recent 12-month period that we have available. We have simple summaries of how quickly patients are being transplanted at this program. Here you can move the slider at the top from 30 days to 1 year, 2 years, 3 years, and the data will change to show you at this program what proportion of their wait list is transplanted by that time. So here we're seeing that at this program, 22% of the patients on the list have been transplanted by 1 year after listing, and that compares with nationally at the right 16%, so slightly higher than the national experience here. And this is what that gives this program that 5-tier rating for getting patients transplanted faster. This is a bit more complex, but I wanted the patients to be aware that we do have data in the reports that look at this program's proclivity to accept organ offers. We do know that some transplant programs are more aggressive in the types of donors they will use, and that may be reflected in when they receive offers for programs. Are they more or less likely than their peers to accept those offers? We do that by presenting what we call an offer acceptance ratio. And something right around 1.0 would mean that they are accepting offers right at the rate that we would expect them to accept them. In other words, they're doing just like the peers would nationally. If a program has a higher than expected offer acceptance ratio, you would see a number higher than 1. Say a 2 would mean that they're twice as likely to accept organ offers than other programs for similar candidates and similar donors. Or something like 0.5 would mean that they're half as likely to accept those offers. And so you can find data here for all offers. You can find data for certain hard to place types of donors. Is this program aggressive in accepting those? Often we see that programs that are more aggressive with their acceptance practices can get their patients transplanted faster. So we hope that these are useful data for the patients. So how are we systematically trying to engage the patient voice? The SRTR has an oversight committee that we would call our SRTR review committee. And just this year, we worked with Hersa to establish 3 subcommittees, one being the Patient and Family Affairs Subcommittee, and then we have what we call a Human-Centered Design Subcommittee, and finally an Analytic Methods Subcommittee. So the top 2 there, I think, are of most relevance to the patients themselves. The Patient and Family Affairs Subcommittee is advising the SRTR on issues of most importance to the patients and families that the transplant system serves. We're trying to systematically hear their recommendations and their voice. The Human-Centered Design Subcommittee then takes those recommendations and helps the SRTR design effective websites, effective reports. If our data are too complex for patients to understand, we know that they would not be useful. And so we're trying our best to take steps toward systematically developing reports that the patients will tell us are really helpful and useful to them. So we're thrilled to have those 2 committees that work together. The Analytic Methods Subcommittee is made up mostly of PhD level statisticians that can make sure that we're getting the methods correct behind all of this as well. Here's just a listing of our current Patient and Family Affairs Subcommittee. I won't go through the names. I will point out that we're fortunate to have Richard Knight as our co-chair of this committee, obviously current president of the AAKP. And so we're really blessed to have Richard's insights helping us here. Here's an image just for some of the work that the Human-Centered Design Subcommittee is helping us with. The image here is from a tool that's being developed by Dr. Corey Schaffhausen, who is our SRTR Human-Centered Design engineer. And this tool is part of a larger project that would help patients better understand the offer process when they're receiving offers for their organ. We want to make sure patients are prepared and ready to receive those offers and understand the relevant issues related to those offers. Just want to make the group aware that the SRTR also this year is embarking on a new initiative that we affectionately call Task 5. And that simply is a reference to our contract with Hersa. Hersa has asked us to engage in a process to identify metrics to assess national transplantation system performance and support informed decision-making by critical audiences. Obviously, the patient voice is a critical audience in terms of data that the SRTR can provide. So we're thrilled to have this new task that will really be underway for the next 5-year period to systematically identify these metrics. We're going to do that in a number of ways that I'll show you on the next slide. So here we see the process for Task 5, just highlighting on the left. It's a 5-year project. We are in year 1 currently. We have formed a steering committee. We are going to host a consensus conference as part of phase 2 that would take place approximately a year from now in the summer of 2022, where we hope to bring together many stakeholders in the transplant system and the data provided by the SRTR. We will hear recommendations. We will then spend the next phase implementing those recommendations and then systematically evaluating that change. On the right, the wheel is meant to represent that this is going to be an ongoing process going forward. We're hoping to systematically, about every 3 years, roll through a process of hearing from the community, making changes, evaluating those changes, and then hearing from the community again. So we will be looking for ways to engage the patient voice throughout this process going forward. We will be conducting patient focus groups as we lead up to the consensus conference. We have Dr. Allison Hart on our team. She is the senior staff for patient and family affairs, and she will be convening a number of patient focus groups. We hope to get broad representation from lots of different patients, genders, racial, ethnic makeup, geographic diversity as well. I'll have some contact information at the end of the presentation if that interests you to participate in those. So where can you stay informed? There's a lot of information. I encourage you to peruse the SRTR's website. If you have questions, the best way to contact us is emailing us at srtr@srtr.org, which is you can find at the bottom of the screen here. We have a newsletter. You can find the sign up for that there, srtr.org/#newsletter, and you can sign up for that. We have a Twitter feed, we have a LinkedIn, and we have a YouTube channel. You can find numerous webinars on our YouTube channel for helping patients navigate our data and website. And so we hope all these resources are available and useful to you. Encourage you to contact us at any time if you have questions about the data. And again, I thank the AAKP for the invitation to be with you today, and I look forward to meeting a number of you in the future as we engage the patient voice more directly. Thank you.
Thank you, Dr. Snyder. We appreciate your insights, and more importantly, we appreciate everything that you're doing for patients.